Orem Institute. I'm very honored to be presenting with this panel today and being one of the co-session panel leads. I especially am honored because of the title of this section on science, research, and innovation. And representing an organization, Orem Institute, for those who don't know it, is based in South Africa with offices in Ghana and Mozambique. And looking at TB and HIV, we do science, research, and innovation as an organization in countries that have the infected populations that we are doing all those implementation pieces on. I'm the director of a project that's funded under Untitled funds with Orem, looking at new TB prevention therapy, 3HP. It's called the Impact for TB project. And I think that project really epitomizes how you can link all these three words together and being able to take evidence, like the Tabellus study that was done by Orem, linking it with all the studies that have been done in the room that people are mentioning and you all have been working on in TB prevention therapy, and then putting it not only into innovation, like new short course prevention therapy for TB, but also implementing it in the field, as Meg and others mentioned, and being able to show evidence for how then you deliver that product or new innovation to people. So, very honored to do that, and part of our partnership is with a consortium of KNCV, CHI, and Hopkins. So I'm also honored to now present our next presenter, Dick Chaisson, who's been working with us very extensively on several studies in latent TB infection under our program. He's a professor of medicine and epidemiology and international health. He's the director of the Johns Hopkins Center for Tuberculosis Research and principal investigator of the Hopkins Center for AIDS Research. His interests focus on TB and HIV infection, including global epidemiology and control, prevention, clinical trials, and public health interventions. And we're honored to have you talk about latent TB infection. Thanks, Dick.
Thank you very much, Karen, and good morning. I'm delighted to be here. As we heard in the opening session, after a period of long neglect, the global health community has finally recognized the importance of prevention of tuberculosis as part of the control strategy. And at the UN high-level meeting in September, the goals of the United Nations were articulated, and that included providing TB preventive therapy to 30 million people in the next 5 years. And this includes the rather unambitious target of only 6 million people living with HIV, but nonetheless the importance of prevention in people with HIV has been included in the UN goals. Likewise, in the Lancet TB Commission report led by Dr. Goosby, the importance of reaching high-risk populations and giving preventive therapy to those most at risk was listed as one of the most important strategies for TB control. And all mathematical models show that TB control cannot be achieved without prevention of TB in those at most risk. So the question is, who are those people at most risk, and how do we reach them? Now, this meeting is focused on HIV, so we'll focus largely on preventing TB in people with HIV. The global guidelines from the World Health Organization say that we should identify people with tests for latent tuberculosis infection where feasible because they'll benefit most from TB preventive therapy. But people with HIV infection should receive TB preventive therapy if they don't have active tuberculosis, irrespective of latent TB testing, and latent TB testing is not a requirement for providing preventive therapy in people living with HIV. This is shown quite nicely in the TEMPRANO study, which we heard about earlier, which gave TB preventive therapy with isoniazid in a randomized factorial design trial with deferred or early antiretroviral therapy with or without IPT. And what they found was that the provision of IPT reduced the risk of serious disease progression with HIV, reduced the risk of tuberculosis specifically, independently of antiretroviral therapy, although both antiretroviral therapy and IPT were better than either alone. And in this study, they included large numbers of people with negative tests for latent TB and showed about a 42% reduction in the risk of TB, even in those who didn't have a positive test for latent TB. They also showed that IPT reduced the risk of death by almost 40%, independent of positive tests for latent TB. So treating people irrespective of a latent TB test is critically important. This past year, the Brazilian Ministry of Health altered their guidelines for TB preventive therapy in people with HIV, recognizing the importance of treating people regardless of a test. And they recommended that those with a CD4 count less than 350 be offered TB preventive therapy regardless of a TST or IGRA result. But with those with a TST, with a CD4 above 350, they recommended treating only those who were TST or IGRA positive. To evaluate this policy, the TRIO study team conducted an analysis from data collected as part of the TRIO study a decade ago. And this was presented in a poster here at this session by my daughter, Lilia Chaisson, looking at the outcomes of TB and death in people with CD4 counts less than 350 and over 350. Here we look at those with CD4 counts over 350, and you see that those who are tuberculin positive have the highest risk of TB, really dominating this graph here. But even those in the lower orange-colored line who have a negative test for latent TB still have an appreciable risk of going on to develop tuberculosis. And if you look at the impact of IPT in these individuals, in the top two lines you see those with a positive TST who did or didn't receive IPT, and IPT reduced the risk of tuberculosis by 90% in this population. So that's something we all know. If we look at those who had a negative TST, we also see that even though the numbers are small, those who received IPT had no cases of TB, and the incidence in those who had a negative test but didn't receive IPT was 0.57 per 100 person years. And more importantly, those with an unknown TST test who weren't tested had high rates of tuberculosis unless they received IPT. Interestingly, those who had a negative test and didn't receive IPT, or those who had an unknown result, had 3 times as many cases of tuberculosis, contributed 3 times as much TB as those with a positive TST who didn't receive IPT. So this supports universal treatment of people with HIV with TB preventive therapy without doing skin testing in a medium burden setting. So what are the options for treating people with HIV to prevent TB? We have isoniazid given for 6, 9, or 3 years or more, 6 or 9 months, 3 years or more, which is endorsed by virtually every organization in the world. We have rifampin for 3 to 4 months, recommended by CDC and WHO, or rifampin and INH for 3 months, recommended by CDC, WHO, and BIVA. We have rifapentine and isoniazid weekly for 12 weeks, or 3-HP, now recommended by WHO as well as the CDC. And then the 1-HP rifapentine isoniazid daily for a month, which was reviewed this week by the WHO Guidelines Development Group, and we'll hopefully see a recommendation for that sometime soon. Now, I've listed in the right-hand column the issues of drug-drug interactions in people with HIV, and I'll highlight some of those as we go through. So INH is the workhorse of TB preventive therapy, and it was it was first used in about 1953. It's been around for a long time. So why isn't everybody on it? Well, there are concerns about hepatotoxicity, peripheral neuropathy, but generally there's been poor adherence when INH is given. There's some drug-drug interactions that I'll mention, and all of this has resulted in appallingly low uptake. Here are the global figures, and you see that for people living with HIV, with a target of 30 million who really should be receiving this, fewer than 1 million people a year actually are getting it. We know that adherence to INH preventive therapy has historically been quite poor. This is from the TB Trials Consortium Study 26 comparing 3-HP to INH. The rate of dropping out of treatment, of stopping treatment for any reason, isn't greater with INH. It's just that you have much more time to do it. And so over the course of time, many more people put on INH for 6 or 9 months or forever, as is done in some settings, just stop taking it for a variety of reasons. So shorter regimens are really essential. Isoniazid has a drug-drug interaction with efavirenz that can be clinically important, but generally is well tolerated. And then we know that the rifamycins have important drug-drug interactions with antiretroviral drugs. And again, I'll highlight these. So these are data from a study of pregnant women with and without tuberculosis, all with HIV infection in South Africa. And it looks at their efavirenz concentrations, the area under the curve, their exposure to efavirenz by their efavirenz genotype, CYP2B6 genotype, either fast or slow or very slow clearers of efavirenz, and whether or not they get INH. Now, INH inhibits the alternative pathway for efavirenz metabolism, and this doesn't matter if you're a fast metabolizer using the CYP2B6. But in those individuals who are slow metabolizers who rely on the alternative pathway, isoniazid actually dramatically increases exposure to efavirenz and can be associated with neurotoxicity. With rifampin, we know that there are many drug-drug interactions, particularly with the protease inhibitors, but the one of greatest interest in recent years has been TAF, and can rifampin be safely given with TAF? And this study published last month nicely addresses this. TAF was given to healthy volunteers with or without rifampin, and they also received tenofovir for TDF for comparison. And giving rifampin with TAF reduced the exposures, both the trough levels and the AUC, by over 50%, and reduced the intracellular concentrations by over a third. Nonetheless, the intracellular concentrations were 4.2-fold higher than that seen with standard TDF without rifampin. And so even in people receiving co-administered rifampin and TAF, the intracellular concentrations are quite high and ought to be adequate. So I think we can probably go ahead and use rifamycins in individuals who are being treated with a TAF-based TAF regimen. The 3HP regimen has been well established in multiple clinical trials, which show that it is non-inferior to longer regimens of isoniazid and almost superior in some studies. It's safer than isoniazid and has much better adherence and treatment completion. If we look at the original study from Soweto, in all HIV-infected individuals, which also looked at a twice-weekly rifampin INH regimen, see that the TB incidence was similar for those treated with the short-course rifamycin regimens to those treated with the control 6-month INH regimen. Interestingly, those who got INH daily for up to 6 years had a reduction of over 25% in TB incidence compared to the control, though this didn't achieve statistical significance. But it does support the notion that in some settings, lifelong INH may be reasonable, but adherence to this regimen is just terrible. And so the short course regimens really have the advantage of much better completion and adherence. The question that emerged in the last 2 years is, can we use 3HP, which is now recommended by the WHO, in people with HIV who are on dolutegravir-based ART? And this is based on a very small healthy volunteer study done at the National Institutes of Health, which showed unacceptably high rates of toxicity. So the Dolphin study was undertaken, and this was part of the Impact for TB project that Karen is coordinating, led by Gavin Churchyard from the Orem Institute. And this was a study of the safety and PK of 3HP in adults with HIV infection on a dolutegravir-based regimen. These were individuals who were virologically suppressed on efavirenz, who were switched to dolutegravir, and after a 2-month washout period were then treated with 3HP. And you can see that the geometric mean trough levels decreased over time. The overall AUC decreased by about 30%. But even though there was a decrease in the trough concentrations and the AUC with dolutegravir, the geometric mean troughs were above the IC90 for dolutegravir at all time points. And all patients were virally suppressed throughout treatment with 3HP. One individual had a blip of 2,300 copies a month after completing her 3HP, but this she was able to resuppress following adherence counseling. Now, earlier this year, we published the results of the 1HP study, 1 month of rifapentine plus isoniazid daily to prevent HIV-related TB. This was a study done in about a dozen countries around the world, in people with HIV 13 years and older, and included people with and without positive tests for latent tuberculosis. And overall, the 1HP regimen was non-inferior to 9 months of isoniazid, as shown here. And no evidence of a rebound of tuberculosis after completion of these short course regimens. And it was safe to give with efavirenz, as shown here. So I'm going to just finish up with some of the questions that now remain with 3HP and 1HP. Can we co-administer it with dolutegravir? The Dolphin study showed that we can. The Dolphin 2 study will look at ART-naive patients who are starting both 3HP and dolutegravir, and the ACTG will study 1HP and dolutegravir. There's still concern about people with very low CD4 counts, but that applies to all regimens. Should we give these drugs periodically? The WIP-TB study that's led by Gavin is finishing up later this year. What about pregnant women? The IMPACT 2001 study will have results very soon that will look at 3HP in pregnancy, and a study of 1HP and 3HP in pregnant women is in development. And then finally, what about children? Study 35 of the TBTC is beginning this month, and we'll look at very young children, and an impact study of 1HP is in development. Karen mentioned the Impact 4TB project, which is addressing, I think, the most critical issue, and that is how do we get this drug, because it's just not available at an affordable price, and the Impact 4TB project is working to make it both affordable and more user-friendly. So to summarize, TB preventive therapy works and is essential for ending the epidemic. It should be given to all people with HIV infection who don't have active TB in both medium and high burden countries, regardless of TST. New short course regimens can greatly increase the use of preventive therapy because they're much easier to take and complete. 3HP is easy, safe, and effective, can be used with efavirenz or dolutegravir. 1HP is easy, safe, and effective, and can be used with efavirenz, and we'll find out about dolutegravir in the coming year. And there's research underway looking at important populations such as pregnant women and children. And then finally, we're not there yet. We may actually be able to do better, and newer drugs and different routes of administration may further improve TB preventive therapy for people living with HIV, which will be the topic of the next presentation. So muchas gracias.